Hello everyone, welcome in SS Medical Classes. I am Dr. Nirbhay Singh from Government Medical College, Kota, Rajasthan. So today we will discuss about meningitis, and this topic is very important for our MBBS university examinations, NEET-PG and INICET examination. So today we will discuss about meningitis, its type, pathogenesis, its clinical features and lab diagnosis. And at last we will discuss some important MCQ and clinical based question based on the topic. So let's start with the meningitis. So what is the definition of meningitis? The definition of meningitis is inflammation of meninges. Now what are meninges? So this is let's see, this is our brain and it is covered by the skull bone. So below the skull bone, our brain is covered by three layer of meninges. From inner to outer side, it is pia mater, then arachnoid, and outermost is dura mater. Now, space between the dura mater and arachnoid is called a subdural space, and space between arachnoid and pia mater is subarachnoid space. Now, what happens in meningitis is it is the inflammation of meninges, basically the arachnoid and pia mater, which also involves the subarachnoid space. Means the space between the arachnoid and pia mater is also involved in meningitis. And due to infective pathogens. Now, uh, what pathogens? It is bacteria, viruses, it may be fungus or parasites, or some toxic chemicals or drugs can also cause inflammation in the meninges. So this is the definition of meningitis, which is inflammation of meninges of arachnoid and pia mater involving the subarachnoid space, maybe due to infective pathogens, which can be viruses, bacteria, fungus, and parasites, or some toxic chemical or drugs. Now come to the types of meningitis. Meningitis is divided into the two broad types. First one is acute meningitis and chronic meningitis. Now, acute meningitis is acute fulminant illness which progress rapidly in few hours to days to acute bacterial, which is also known as pyogenic meningitis. Bacterial meningitis is also known as pyogenic meningitis, and acute viral meningitis. So, in acute meningitis, the illness progresses very rapidly in few hours to days into acute bacterial or acute viral meningitis. In the case of chronic meningitis, the illness persists for more than 4 weeks. And what is the main cause of chronic meningitis is due to mycobacteria, such as Mycobacterium tuberculosis, which causes tuberculosis in and fungus. So chronic meningitis is an illness which persists for more than 4 weeks due to mycobacteria is the most common cause and important cause such as Mycobacterium tuberculosis and fungus. If we talk about the highest global burden, which type of meningitis is most common, then it is the bacterial meningitis. Acute bacterial meningitis is most common globally, and it is worldwide. The acute bacterial meningitis is most common. Now the agents which cause meningitis. So first we have here the bacterial agents. The bacteria which causes meningitis. First one is Streptococcus pneumoniae. It causes pneumococcal meningitis, and Streptococcus pneumoniae is responsible for 50% of meningitis cases. Second one is Neisseria meningitis. The second one is Neisseria meningitis, which causes meningococcal type of meningitis. The third bacteria we have Streptococcus agalacti. It causes meningitis in neonates and elderly people greater than 60 years of age. Streptococcus agalacti causes meningitis in neonates and elderly people more than 60 years of age. Fourth one, Listeria monocytogenes, also causes meningitis in neonates and elderly people. And Haemophilus influenzae and other gram-negative bacilli like E. coli and Klebsiella, Pseudomonas and Acinetobacter. So 6 bacterial agents we have. First one, Streptococcus pneumoniae causes pneumococcal meningitis, responsible for 50% of the meningitis cases. Second one we have Neisseria meningitis, which causes meningococcal meningitis, and Streptococcus agalacti Listeria monocytogenes causes meningitis in neonates and elderly people more than 60 years of age. Haemophilus influenzae and other gram-negative bacilli like E. coli, Klebsiella, and Pseudomonas and Acinetobacter also causes bacterial meningitis. Now come to the second, the viral agents of the meningitis. Viral meningitis is also known as aseptic meningitis. So the onset of viral meningitis is 1 to 3 days, and it is also known as aseptic meningitis. So viral agents are enteroviruses, the herpes virus, herpes simplex virus, HSV, mumps virus, and West Nile virus, which is a type of arbovirus, and it's spread by mosquito. Fifth, we have HIV, human immunodeficiency virus, and LCMV, lymphocyte chorio choriomeningio lymphocytic choriomeningivirus LCMV. Now seventh one, Epstein-Barr virus, also causes viral type of meningitis. So these are the bacterial agents. So these are the viral agents, which is enteroviruses, herpes simplex virus, mumps virus, West Nile virus, and HIV virus, lymphocyte choriomeningic virus, and Epstein-Barr virus. Now, chronic lymphocytic meningitis. Chronic lymphocytic meningitis have onset between weeks to months, and it may be due to Mycobacterium tuberculosis. The most common in India, the most common cause of chronic lymphocytic meningitis in India is Mycobacterium tuberculosis, which causes TB, or fungus, or malignancy, or syphilis. The most common cause is Mycobacterium tuberculosis, but it can also be caused by fungus, malignancy, or syphilis. Now come to the fungal agents of meningitis. So first fungal agent we have Cryptococcus. It is the most common agent of fungal meningitis. Cryptococcus neoformans and Cryptococcus gettii. Cryptococcus gettii. Second one is Candida. That is Histoplasma capsulatum, which causes histoplasmosis. Fourth is Blastomyces, and fifth is Coccidioides. So these are the fungal agents. Cryptococcus, the most common, and Candida, Histoplasma capsulatum, Blastomyces, and Coccidioides. Now in bacterial agents, the Mycobacterium tuberculosis, which is also the agent of TB. This meningitis is also known as tubercular meningitis or TBM. TBM, tubercular meningitis. Now other bacterial agents we have Borrelia burgdorferi, which causes borreliosis. Borreliosis. It also causes Borrelia burgdorferi also causes meningitis. Third, we have Treponema pallidum, that is agent of syphilis. So third one we have Treponema pallidum. It is the agent of syphilis, which causes STD, but it also causes meningitis also. So we have discussed various types of agents of meningitis, pyogenic bacterial agents of meningitis, viral agents, fungal agents. So now, so now we will discuss about the CSF findings in different types of meningitis. So you can see the table here in CSF findings in different types of meningitis. The first column we have the characteristic features, that is the findings, and in the second column we have the normal value, which is present in the normal individuals, the normal value, and the first we have pyogenic or bacterial meningitis, tuberculous meningitis, and viral meningitis. So the first finding is CSF pressure, which is measured in of water. The normal CSF pressure is 50 to 150 of water. But in case of pyogenic and bacterial meningitis, it is highly elevated, which can be greater than 180 of water. In case of tuberculous meningitis, it is moderately elevated. And in viral meningitis, it is slightly elevated or can be normal also. Now the second characteristic feature is TLC, total leukocyte count, that is in per cube. The normal value of the TLC is 0 to 5 cells per cube. But in pyogenic meningitis, we can see it is having very high value between 10 to 10,000 count per cube. In tuberculous meningitis, the TLC is 10 to 500, and in case of viral meningitis, 25 to 500. So now what are the different type of cell types which are seen in CSF in different types of meningitis? So predominant cell type, normally we have lymphocyte as a predominant cell type. In pyogenic or bacterial meningitis, neutrophil is the predominant cell type which is seen in the CSF. In tuberculosis and viral meningitis, lymphocyte is the predominant cell type. The fourth characteristic feature is glucose. The normal glucose level in CSF is 40 to 70 milligram per deciliter. In case of pyogenic meningitis, it can be less than 40 milligram per deciliter. Decreased, it can be decreased or either absent. In case of tuberculous meningitis, it is 20 to 40 milligram per deciliter, means slightly decreased. In viral meningitis, very important that the glucose is normal. The glucose in CSF is normal value in viral meningitis. Now total proteins. The normal value of protein in the CSF is 15 to 45 milligram per deciliter. In case of pyogenic meningitis, we have 100 to 500. That is, proteins are increased in pyogenic meningitis as well as in tuberculous meningitis. The value in tuberculous meningitis is 100 to 500 milligram per deciliter. In viral meningitis, the protein level is normal. So in viral meningitis, the glucose and the protein level in the CSF is normal. So we have studied the CSF findings in different types of meningitis. Now what are the difference in their clinical features? The first one is fever. In case of pyogenic or bacterial meningitis, the fever is high to moderate, and low grade fever is present in tuberculous meningitis. And in case of viral meningitis, we have moderate fever, and fungal meningitis have low grade fever. So the fever is low grade in tubercular and fungal meningitis. So if the fever is low grade, it can be either tuberculous or fungal meningitis. Neck rigidity. The neck rigidity is marked in pyogenic meningitis and it is mild in other types of meningitis. For example, tubercular, viral and fungal. Now, we have mild neck rigidity, but marked neck rigidity is present in pyogenic meningitis. The patient have altered sensorium early. If the altered alternation in the sensorium is early, it is present in pyogenic meningitis and late in tuberculous, viral and fungal. Clinical nerve palsy. It is rare in the case of pyogenic meningitis, but third and fourth nerve palsy is common in tuberculous meningitis. In case of viral meningitis, it is absent, and in fungal meningitis, the clinical nerve palsy is rare. Rashes. Rashes will be only seen in pyogenic meningitis, and which type of pyogenic meningitis? It is meningococcal. So rashes are present in meningococcal meningitis caused by Neisseria meningitidis. In other types of meningitis, tubercular, viral and fungal, rashes are not present, these are absent, only present in meningococcal meningitis. HIV and or immunocompromised. In case of pyogenic meningitis, it is absent. In case of tuberculous meningitis, it may be present, but in viral meningitis, it is absent. In case of fungal meningitis, it is common. Now, hydrocephalus condition is common in tuberculous meningitis and can be present in fungal meningitis, but it is absent in pyogenic and viral meningitis. So these are the 7 parameters. So now come to the acute bacterial meningitis, that is pyogenic meningitis. Now causative agent we have discussed previously, Streptococcus pneumoniae the most common agent, uh, Haemophilus influenzae, Neisseria meningitidis. The causative agents of bacterial meningitis we have discussed previously. Now what is the pathogenesis of acute bacterial meningitis? It is transmitted through droplet infection, respiratory secretions and close contact. The the bacteria gain access into the meninges by either hematogenous spread. It is the most common route for entry to subarachnoid space. It's the space between the arachnoid and biomatter. So hematogenous spread is the most common route for entry to subarachnoid space. Now the second route, we have the direct spread from infected site. The infected site which can be present close to the meninges, for example in case of chronic suppurative otitis media or mastoiditis, sinusitis or dental infections. There can be direct spread from the infected site to the meninges, which can cause meningitis. And now the third cause is the anatomical defects in CNS. Now there can be anatomical defects in CNS due to surgery, trauma, or congenital defects which are present since birth. Now, what are the predisposing factors which causes meningitis? The first one is age. Now, the meningitis it is highest in neonates. Now, why it is high in neonates? Because of their immature immune system. Their immune system is not mature enough to handle the infection, or due to acquiring organisms from mother's birth canal. Now, during the birth, the neonates can acquire the organisms from the mother's blood canal, and there is also increased permeability of the blood brain and barrier. So the pathogen can easily cross the blood brain barrier and gain access to the meninges and will cause the disease. Second factor, we have the vaccination. Now due to the second factor, we have the vaccination. Now we can see the incidence of meningitis due to Haemophilus influenzae is decreased nowadays. So why it is decreased? It is decreased because of HIV vaccination. So because of the HIV vaccination, the incidence of meningitis due to Haemophilus influenzae is decreased. So it is the second predisposing factor. Now what are the factors that promote infection at primary site? It is the respiratory tract. It can be diabetes or due to alcoholism or immunosuppression if the patient is taking steroids, and during after organ transplantation the patient is taking immunosuppressive drugs. Due to immunosuppression, it can promote infection at the primary site and then can cause the meningitis. The other factor is splenectomy or any chronic debilitating illness. Now, there can be presence of CNS stents or there is a breach in the blood-brain barrier through which the organisms can gain access to the meninges. Now, now we will discuss about the clinical manifestations. In clinical manifestation, first we can see the incubation period is 2 to 10 days, which is average to 4 days. Now the first clinical manifestation, we have high grade fever. The fever is of high grade and there will be vomiting, intense headache, altered consciousness, papilledema, occasionally photophobia. Now the signs are nuchal rigidity. Now the signs are nuchal rigidity, which is stiffness, neck resist, passive flexion. So if we try to flex the neck of the patient, then it will resist passive flexion. It is known as nuchal rigidity. The second sign, we have the Kernick sign, that is stiffness of the hamstring muscles, and Brodzinski sign. Now in this diagram you can see the Kernick sign. If we try to extend the now in this image we can see the Kernick sign. If we flex the hip of a patient to 90 degree and the knees flex and knees also flex to 90 degrees, then the extension of the knee is painful or there is limitation in extension which elicits pain or limited extension. In case of Brodzinski sign, the patient resists passive flexion of the neck. So if we try to flex the neck of the patient, it will resist flexion and it will cause involuntary flexion of hip and knee. So it is Brodzinski sign. Now the clinical manifestation in infants are high grade fever, There will be poor feeding, irritation in infants, and there are bulging fontanelle. And neck stiffness may or may not be present. The complications of meningitis can be meningoencephalitis, presence of seizures, raised intracranial pressure. The normal value of intracranial pressure is between 7 to 15 mm of Hg, but it can be raised as a complication of meningitis and decreased cerebral perfusion pressure. So, as a complication of meningitis, the intracranial pressure is raised and decrease in the cerebral perfusion pressure. Now, what are intracranial pressure and cerebral perfusion pressure? The normal intracranial pressure is between 7 to 15 mm of Hg, and cerebral perfusion pressure is closely linked to intracranial pressure. Now, we use this formula to calculate the cerebral perfusion pressure, which is equal to mean arterial pressure minus intracranial pressure. And the normal value of cerebral perfusion pressure is 70 to 100. The normal value of CCP is 70 to 100. And a CCP of less than 50 results in permanent neuralgic damage. So in this formula, the CCP equal to mean arterial pressure minus ICP, intracranial pressure. Now we can calculate the mean arterial pressure by using the second formula. As we can see, the mean arterial pressure is equal to systolic blood pressure plus 2 by third of diastolic blood pressure. Now we can calculate the mean arterial pressure by using this formula. The CCP can hence be derived by using the mean arterial pressure minus intracranial pressure. Now the cerebral perfusion pressure is essential for the normal blood flow and oxygenation of brain. So if there is decrease in the CCP, which results in the reduction in blood flow and decreased oxygenation of the brain, so it causes death. Hence CCP less than 30 results in death of a patient. Now the fifth clinical manifestation we have stroke. Now how does the stroke happen in case of meningitis? As we can see, it is primarily through the cerebral vasculopathy. What happens in the cerebral vasculopathy? There is an intense inflammation of the meninges, spreads to blood vessels, where there is an intense inflammation of the meninges which spreads to blood vessels, causing narrowing and thrombosis. It is clotting and reduced blood flow to the brain. And because of the reduced blood flow to the brain, there is decrease in oxygenation, hence it causes death of the patient. Now the other clinical manifestation, which is found only in meningococcal meningitis, is presence of purpuric rashes. So as we have discussed the clinical manifestations of the meningitis, now come to the lab diagnosis. So in lab diagnosis, the first point we have it is purulent infection within the subarachnoid space. As we know that there is a inflammation of the meninges, arachnoid and pyometer, which also involves the subarachnoid space. And we have elevated PMNC. Polymorphonuclear cells are elevated. And very low glucose in CSF. It is also seen in pyogenic meningitis. And leukocytes are mostly polymorphonuclear leukocytes, which have the values 1000 between 5000. So for the lab diagnosis, we have to first collect the specimen. So we have two types of specimen. First one is CSF and the blood culture. CSF is the most ideal and the most precious specimen. So in case of suspected meningococcal meningitis, we can also take nasopharyngeal swabs pus or scrapings from the rashes, and these are for suspected meningococcal meningitis. We can also take the nasopharyngeal swabs, pus or scrapings from the rashes, and the transport media is also used in this, which is Stuart medium, and which are inoculated into selective media. Now, what are the selective media which are used in meningococcal meningitis? We have two selective media: it is Thayer-Martin medium and New York City medium. So, in case of meningococcal meningitis, the transport media which is used in Stuart medium, and the selective media are Thayer-Martin medium and New York City medium. Now, the third lab diagnosis are CSF findings. We have seen previously CSF findings in different types of meningitis. Now, the next lab diagnosis we have CSF microscopy, means gram staining of the CSF, which suggests which etiological agent is present in the CSF. So, if we do the gram staining of the CSF, and if there is a presence of Streptococcus pneumoniae, then the appearance will be seen as gram-positive diplococci. In case of Streptococcus pneumoniae, the bacteria will be it is gram-positive and diplococci, and the bacteria will be seen as flamed or lanceolate shaped with a clear halo, and it is also capsulated, means like a shape of a flame. Now, in case of Neisseria meningitis, which is gram-negative diplococci, now the appearance in CSF of Neisseria meningitis is flattened, lens or half moon shaped. As you can see, it is half moon shaped or lens shaped. In Haemophilus influenzae, it is pleomorphic gram-negative coccobacilli and it is capsulated. If the meningitis is caused by E. coli or other gram-negative bacteria, then these bacteria are arranged singly, and Streptococcus agalacti, which is a gram-positive cocci, it is arranged in short chains. As you can see, there are short chains like this. And at last, we have Listeria monocytogenes. It is also gram-positive short bacilli, but it is often confused with diphtheroids. Now, the other lab diagnosis, we have direct antigen detection. Now, how the direct antigen detection? How do we detect the antigen? It is by either the latex agglutination test. In latex agglutination test, we detect the capsular antigens of Streptococcus pneumoniae, Streptococcus agalacti, Neisseria meningitis, and Haemophilus influenzae. So, in antigen detection by latex agglutination test, we detect the capsular antigens of Streptococcus pneumoniae, Streptococcus agalacti, and Neisseria meningitis and Haemophilus influenzae. Now, lab diagnosis can also be performed from urine. In case of urine, the C polysaccharide antigen can be detected of Streptococcus pneumoniae by immunochromatographic test. Now, different types of culture media which are used for diagnosis of meningitis. First one, we have enriched media. The enriched media which can be used in meningitis are chocolate agar or blood agar, and the differential media which is used is McConkey agar. So the two types of culture media are used: enriched media and differential media. In enriched media, we use chocolate agar or blood agar, and in differential media, we use McConkey agar. And the culture plates are incubated at 37 degrees Celsius, which is the optimum temperature for the growth of bacteria. Now come to the culture and identification properties of agent. If we do the culture in blood agar, how the bacteria will appear. So now come to the culture and identification properties of agents. In case of Streptococcus pneumoniae, if we do the culture of CSF in blood agar, then it will show the alpha hemolytic colonies in case of Streptococcus pneumoniae. In Neisseria meningitis, it will show non-hemolytic colonies in blood agar. In Haemophilus influenzae infection, the blood culture in blood agar will show Streptococcus aureus streak line and which shows satellitis. And the fourth one is Streptococcus agalacti. The culture of CSF in blood agar, in case of Streptococcus agalacti, it will form beta hemolytic colonies with CAM test positive. Now the other gram-negative agents like E. coli, Klebsiella, it will form the lactose fermenting colonies. And the Pseudomonas and Acinetobacter are also the gram-negative agents, but they will form the non-lactose fermenting colonies in culture media. And at last we have the Listeria monocytogenes. So if we do the blood culture of, if we do the culture of Listeria monos, if we do the culture of CSF in blood agar, it will form the beta hemolytic colonies. So if the beta hemolytic colonies are forming, then it can be Listeria monocytogenes or Streptococcus agalacti. In case of Listeria monocytogenes, the selective media which is used is not the chocolate agar or the blood agar, but we use the Pelcam agar in this case. Now the serum analysis and serology can also be done in case of meningitis, which is in case of serology we detect antibody by the technique ELISA. This is enzyme-linked immunosorbent assay. And the molecular methods can also be used, which are multiplex PCR, multiplex real-time reverse transcriptase PCR, biofire film array. So it is the lab diagnosis of acute bacterial meningitis, that is biogenic meningitis. Now the lab diagnosis for chronic lymphocytic meningitis is we use Indian preparation of CSF. So in Indian, mm, 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 हाँ टच करने से हाँ, कर ले इधर करना इधर राइट साइड में करने से आगे आएगी इससे गायब हो जाएगी ऐसे है। नहीं अगर आप इधर को करोगे लेफ्ट में तो वो बैक को जाती है आगे करोगे तो आगे आती है बीच में नहीं होता कुछ इसलिए- लेफ्ट राइट तो है नहीं लेफ्ट राइट तो डाली नहीं Light black. So grey. नहीं सफेद 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 कर लिया. So हाँ. So let's summarize what we have studied till now. What we have learned till now. So let's summarize what we have learned till now about acute bacterial meningitis. So we have seen the bacterial agents which causes the meningitis. दाल जलने लगी. इधर से चेंज करना पड़ेगा. इधर से इसमें सफेद है नहीं. इसमें सफेद आ नहीं रही. सफेद नहीं आएगा. So let's summarize what we have learned till now. So in acute bacterial meningitis, we have seen the causative agents of we have learned the causative agents of bacterial meningitis, which are Streptococcus pneumoniae, the most common cause of acute bacterial meningitis, and the Neisseria meningitidis. The Haemophilus influenzae and Listeria cytogenes, and other gram-negative bacilli, for example, E. coli, Pseudomonas, Acinetobacter. So these are the bacterial agents of acute pyogenic meningitis.
वो तो अपना फायदा देख रहा है, बाहर में नहीं है ना।
नहीं, समराइज पूरा करूं? वो तो बहुत लिखना पड़ेगा।
स्टार्ट करो, बाकी सब काटी जाएगी ना।
नहीं नहीं, क्या क्या समराइज करूं इसमें? खाली
समराइज करो जो तुमने अभी तक पढ़ाया उसको समराइज कर दो। पढ़ाने नहीं आता है, सीख लिया।
होता ही तो बहुत बता दिया हमने।
अरे तो कौन चीज बता दो ना मेरे में। तो हमने बताया कि मेनिंजाइटिस क्या है, इन्फ्लेमेशन आता है मेनिंजेस है, इंक्लूडिंग सबएक्वायर स्पेस किससे होती है, इट में भी बैक्टीरिया, इट में भी फंगस, इसमें भी इट में भी टाइप की हो सकती है, ठीक है ना। अब मेन बैक्टीरिया दी जा रही फंगस ये ऐसे करके बता दें। अब हमने लैब डायग्नोसिस बताई, तो अगर हम सीएसएफ एग्जामिनेशन देखें तो अब हमारी जो क्लिनिकल पिक्चर है उसमें फीवर हाई ग्रेड का होगा और हमारी प्रोटीन इंक्रीज कर जाएगी, ग्लूकोज हमारा बहुत कम हो जाएगा, जैसे 14 मिलना पर डेसिलीटर हो जाएगा। जितनी भी सेल्स होंगी वो 1,000 से 5,000 के बीच होंगी। नदी यार मोस्टली लिपोसाइट से ऐसे बता दो ना यार, तो तुम्हें तो याद हो गई होगी ना। फिर तो याद हो गई होता।
तो नहीं जोड़ डालना। So let's summarize what we have learned till now for acute bacterial meningitis. So we have seen the causative agents, which are Streptococcus pneumoniae, which is responsible for the 50% of the cases of meningitis, and Streptococcus pneumoniae is the most common agent. Other one is Neisseria meningitidis, an agent of meningococcal meningitis. The third agent we have the Streptococcus agalacti.
जो बोलो वो साफ बोले करो, इतनी जल्दी बोल दी नहीं है, जो बर्ड
अच्छा
निकालो उनसे साफ निकालो।
अच्छा
ये ना
हाँ
बीच बर्ड में जाते हैं।
हम्म
इंसान यानी ये बोलना है इतनी जल्दी कोई क्या है उनको
So the third one is Streptococcus agalacti, which causes meningitis in neonates and elderly people. And the fourth one is Listeria monocytogenes. Listeria monocytogenes, which also is responsible for meningitis in neonates and elderly people greater than 60 years of age. And the other agent we have the Haemophilus influenzae, and some other gram-negative bacilli which also causes acute bacterial meningitis are E. coli, Klebsiella, Pseudomonas, and Acinetobacter.
मत बताओ मत, दूसरी स्लाइड है ना।
और स्लाइड लेनी
नहीं
पड़ेगी।
वो रिकॉर्डिंग हो रही है।
हाँ
बता भी सकते हो, दार करना इसमें, दार दार करो, दार अच्छा होता है, इसमें बड़े निकलते हैं। अरे कुछ यार मैंने बहुत बात करी।
हाँ वो तो एजेंट को बता दिया मैंने, ये स्लाइड हो गई। So these are the bacterial agents of the acute bacterial meningitis, and we have also seen the CSF findings in different types of meningitis. For example, in acute pyogenic meningitis, the CSF pressure is, as we have seen the CSF findings in different types of meningitis. In case of acute pyogenic meningitis, the first we have seen the CSF pressure, which is highly elevated and more than 180 mm of water. Next, the total leukocyte count. In acute bacterial meningitis, it is between 10 to 10,000. And the predominant cell type which we have seen in the acute bacterial meningitis is the pre बहुत तेज हो गई ना the predominant cell type which we have seen in the acute bacterial meningitis is the presence of neutrophil. And the glucose level in acute bacterial meningitis is less than 40 milligram per deciliter. It can also be decreased or either absent. The glucose is very less, which is less than 40 milligram per deciliter, or it can be also absent. Now the total protein, the level of protein in acute bacterial meningitis is between 100 to 500 milligram per deciliter. And we have also seen that in case of viral meningitis, if we compare the acute bacterial meningitis to viral meningitis, the glucose and the protein level is normal in case of viral meningitis. But in acute bacterial meningitis, the glucose level is less than 40 and the glucose can also be absent. And the protein level is between 100 to 500 milligram per deciliter. And then we blend the clinical features of acute pyogenic meningitis. Now the first clinical feature we have seen it is the fever. In case of pyogenic meningitis, a high to moderate fever is present. The second clinical feature we have seen is neck rigidity, which is highly marked in case of acute bacterial meningitis. And the very important feature in case of acute bacterial meningitis is presence of rash. But the presence of rashes is seen only in case of meningococcal meningitis. So these are the main clinical features we have seen in the acute bacterial meningitis. So we have also learned that what are the predisposing factors in case of acute bacterial meningitis, the age. So the acute bacterial meningitis is highest in neonates as compared to adults. Now, why it is highest in case of neonates? It is because of three reasons we have. First, they have immature immune system. Their immune system is immature. Now, we have also learned the predisposing factors. We have seen in case of HIV, in case of HIV vaccination, that there is a decrease in incidence of meningitis due to Haemophilus influenzae. Now, the important clinical manifestation, the signs that we have seen are the Kernick sign and the Brzezinski sign. In case of Brzezinski sign, the patient does passive flexion of the neck, and in Kernick sign, there is rigidity of the hamstring muscles. Now, the important clinical manifestation in case of infants, we have seen there is a presence of high-grade fever in infants. They have poor feeding, and the important feature is bulging fontanelle in case bulging fontanelle. And we have also learned about the complications of acute bacterial meningitis. मिठाई लूँगा से हाथ से मिल जाता है.
तो काट दो जो समराइज करते हैं ना थोड़ा फास्ट होता है समराइज करने में फास्ट होता है
फास्ट बोलूँ तो फिर लिखूंगा तो लिखने में टाइम लगेगा.
ठीक ठीक कोई बात
या तो फिर समराइज ऐसे भी तो कर सकते हैं, अगर बिना लिखे करेंगे स्लाइड दिखा दें कि स्टॉप हो
नहीं
रहा
स्लाइड
है.
दिखानी है लिखते जिसको नहीं पढ़ा तो मजा ही नहीं आता है। पढ़ते नहीं है तो प्रेम। आगे बढ़ जाओ, पुरानी बात देखो, हमको पता नहीं।
इतना तो हो गया, यहाँ तक तो बता ही दिया। So now we will discuss the lab diagnosis of the chronic lymphocytic meningitis. So in case of chronic lymphocytic meningitis, we use the Indian ink preparation of CSF. Now the Indian ink preparation of CSF shows,
जैसे कागजी वर्जन थोड़ा सा बता दो जैसे मैं आपको।
बताती थी तो पहले।
हाँ, एक बार दोबारा बता दो। तभी सुन लो।
So now we will discuss about the lab diagnosis of chronic lymphocytic meningitis. Now what are the causative agents? As we have learned earlier, the causative agents of chronic lymphocytic meningitis is most common are the mycobacteria, and which is Mycobacterium tuberculosis. Or it can be fungal also. So these two are the agents of chronic lymphocytic meningitis. Most common is the Mycobacterium tuberculosis. So for the lab diagnosis of chronic lymphocytic meningitis, the Indian ink preparation of CSF shows capsular antigens, which are also known as cryptococcal antigen, against dark ground microscopy to diagnose fungal meningitis. So as we have learned earlier that the chronic lymphocytic meningitis is caused by most commonly due to Mycobacterium tuberculosis, but it can also be caused due to fungal agent. The most common fungal agent we have seen is Cryptococcus neoformans or Cryptococcus gati. So in case of fungal meningitis, we use Indian ink preparation of CSF, which shows capsular antigen, that is cryptococcal antigen, against dark ground microscopy to diagnose fungal meningitis. And the Giel-Nielsen stain, it is the CB-NET, and we use the Giel-Nielsen stain CB-NET for detection of acid-fast bacilli in case of Mycobacterium tuberculosis. And the CSF PCR is done for viral and tuberculous meningitis. And the CSF lactate in case of which is the and the fourth one is CSF lactate. The level of CSF lactate is high in bacterial and TB and normal in viral meningitis. So so till now we have learned the acute bacterial meningitis, different types of meningitis, its pathogenesis, which is a pathogenesis which we have seen that it mainly spreads due to hematogenesis spread or spread due to the infection is the primary site. So now we will discuss about the multiple choice question, which are important for the NEET-PG and NECET examination. So the first question that we have, it is a 20-year-old boy having high grade fever since 10 days with ear discharge of pus from right ear since 3 months, have altered consciousness, photophobia, neck rigidity. CSF examination reveals polymorphonuclear leukocytes, which are 1800 cells per mm cube. and the CSF glucose is 20 milligram per deciliter. So we have to see the find the diagnosis. So the options are: first, pyogenic meningitis, viral or aseptic meningitis, fungal meningitis, or TBM, which is tubercular meningitis. So in this question, if you can see presence of CSF examination reveals presence of polymorphonuclear leukocytes, the PMNNL, which have very high concentration of 1800 cells per mm cube, and the CSF glucose level is very low, and the patient is having altered consciousness, photophobia, and neck rigidity. So because of these symptoms, it is the case of pyogenic meningitis. As we have learned that in case of pyogenic meningitis, the glucose level is less than 40 milligram per deciliter, and the TLC, total leukocyte count, is high, which are mainly having the neutrophils, and the PMNL level is very high, 1000 to 5000 cells per mm cube. So in this clinical question, we have the case of pyogenic meningitis. So option first is correct, the pyogenic meningitis. Now come to the second question. A 30-year-old female with a history of low-grade fever around 99 to 101 degrees Fahrenheit since 3 months, with decreased appetite, generalized weakness, headache, photophobia, 2.5 months, family member taking treatment of tuberculosis. On lab examination, patient was found to be diabetic. CSF examination shows blood glucose, that is 35 milligram per deciliter, and the predominant cell types is all lymphocytes, and the protein is moderately raised. Cobweb plot on standing CSF. And on examination, patient have mild Kernick sign, and the Gill-Nansen staining of CSF shows acid-fast bacilli, which is +3, and CB-net positive. We have to find out the diagnosis. So the options are: first, pyogenic meningitis, viral meningitis, that is aseptic meningitis, fungal meningitis, or tubercular meningitis. So in this question, as we can see, the symptoms of general meningitis are also given at headache, photophobia, and the patient is also taking treatment of tuberculosis. The patient's family member is taking treatment of tuberculosis, so there is a high chance of the patient having the infection of tuberculosis. And on lab examination, patient was found to be diabetic. As we have learned in case of tubercular meningitis, the clinical feature is HIV or immunocompromised state of a patient, and tubercular meningitis is also seen. And the CSF examination is shows blood glucose, which is less, it is 35 milligram per deciliter, and the predominant cell type is lymphocyte. The protein is moderately raised, and the Cobb-Webb plot, which is a characteristic feature of tubercular meningitis. So the diagnosis and the answer of this question is TBM. It is tubercular meningitis. Right. So now let's move to the question number 3. A HIV positive patient, which is 45 years old male, has mild fever since 4 months, and he has dwellings of pigeon in his home and has altered consciousness, and the CT scan shows space occupying nodular lesions, and on examination of the CSF shows mild increase in proteins, mild lymphocytosis, and mild decrease in CSF glucose. The Indian ink preparation of CSF shows capsular halo against dark ground microscopy. Serum shows cryptococcal antigen positive. What is the diagnosis? The options are: first, tubercular meningitis; second, aseptic meningitis; third is cryptococcal meningitis; and the fourth one is pyogenic meningitis. So as we can see in this question, the patient is having mild fever. which suggests the infection is of bacteria. So as we can see in this question, the patient is having mild fever. Now mild fever is associated with both fungal and tuberculous meningitis. In both fungal and tuberculous meningitis, the patient will be having the low grade fever. Now the second hint that is given in the question is he has dwellings of pigeon in his home. Now the dwellings or droppings of the pigeon contain the fungus Cryptococcus neoformans, which is associated with the cryptococcal meningitis. Now, further more symptoms are given. The CT scan shows space occupying nodular lesions, and the CSF examination shows mild increase in protein, which is also a feature of cryptococcal meningitis. And there is mild lymphocytosis, and the predominant cell type it is lymphocyte, and there is mild decrease in CSF glucose. In viral meningitis, the glucose and the protein level is normal, but there is a mild decrease in glucose level in case of fungal meningitis. It is which is associated with Cryptococcus neoformans. And the most important hint which is given in the question is Indian ink preparation of CSF shows capsular halo against dark ground microscopy, and the serum shows cryptococcal antigen positive. So the question itself having the answer that is cryptococcal antigen is positive. So according to it, the diagnosis is of cryptococcal meningitis. So option third is correct. Now let's move to the fourth question. A 8-year-old boy, mild fever since 7 to 8 days, altered sensorium, carnic positive with slightly decreased appetite. CSF examination shows normal sugar, slightly increase in protein and lymphocytes. What is diagnosis? The options are pyogenic meningitis, viral or aseptic meningitis, fungal meningitis, or tubercular meningitis. So as we can see in this question number 4, the patient is having mild fever since 7. So as we can see in question number 4, the patient is having mild fever since 7 to 8 days. An altered sensorium, carnic sign is positive with slightly decreased appetite. And CSF examination shows normal sugar and slightly increased protein and lymphocyte. So lymphocyte are the predominant cell type in viral meningitis and also in tubercular meningitis. But both of these, in tubercular meningitis, the blood glucose level is decreased very much, or it is either absent in the CSF. So tubercular meningitis will be the wrong option. So other symptoms suggest increase in protein and a decreased appetite, and the mild fever is 7 to 8 days, suggests it is a viral meningitis. So in question number 4, the viral or aseptic meningitis, second option is correct. So this is all about meningitis. So if you like the content, then like this video and subscribe the channel. So thank you for watching and keep on watching.